Okay, I remembered. Sorry, Dr. Ahearn. Our speaker today is Vivian Tarkul. Vivian learned about BAAKP over 10 years ago when her father was diagnosed with end-stage kidney disease. She then served on our board of directors and eventually became our newsletter editor for Kidney Connections. Vivian has been phenomenal, where she published our newsletter 3 times a year while she was finishing her terminal degree. Vivian holds a Pharm.D from the University of the Pacific. Vivian also received her MS from San Jose State University and BA from the University of California at Berkeley. As Vivian gives her talk today, you'll notice in the bottom of your screen is a Q&A button, and you can ask your questions there. She and Dr. Ahearn will answer your questions after the presentation. And with that, I'm going to turn it over to Dr. Tarkul. I mispronounced that. I'm sorry.
No worries. Thank you, Deborah, for your introduction. Okay, let me go share the screen. Give me a second here. Okay. All right, welcome. So my name is Vivian Tarkul, and thank you for joining us today and bettering your health. I have been interested in the topic of kidney disease for a number of years. As a former BAAKP board member and having a father who has battled with CKD, I understand you. And for those of you who don't have CKD, I'm sure you know someone who has CKD, whether it be your sibling, your spouse, or someone close to you. It is challenging to have CKD alone, and you're not alone. With BAAKP, we are here for you. So I had a conversation with Dr. Ahearn regarding about a good topic for the BAAKP 2022 educational seminar. And Dr. Ahearn suggested a new class of SGLT2 inhibitors that every kidney patient should be informed about. And can these SGLT2 inhibitors drugs slow the progression of chronic kidney disease? So please consult with your physician as individual cases may vary. And then these are some of the common abbreviations or acronyms that would be used during this presentation. And so in this presentation, we will start with the function of a normal kidney, followed by what happens when a kidney has, when it has CKD. And then we will talk about the current RAS drugs that every kidney patient is using for kidney protection. Then we will go into the SGLT2 inhibitors that's used currently in diabetic patients and now study in kidney patient population, especially CKD. Then we will highlight the findings of the Credence and Dapa-CKD trials. And let's see, okay. So most people have 2 kidneys, as you can see here with the, it looks like a kidney bean shape, and it's 10 to 15 centimeters long. It's located on the left and right side of the spinal cord, deep in the retroperitoneal space. The kidney function is basically function as a homeostasis through 1, cleansing the blood of toxin. Number 2, it optimizes the body fluid stasis. And number 3, it balances electrolytes. So kidney function is expressed in glomerular filtration rate, or GFR, and a normal kidney typically is greater than or equal to 90 milliliters per minute per 1.73 meters square. So when a kidney is not working properly, we have harmful toxin and excess fluid build up in the body. And according to KDIGO, CKD is defined as when the GFR is less than 60 milliliters per minute for more than 3 months, And then when a patient has end-stage kidney disease, patients may require dialysis or kidney transplant. So according to the CDC, type 2 diabetes is the #1 cause of kidney failure, followed by high blood pressure. And as you can see here on the right side of this PowerPoint, is a graph that shows that the CKD in the US affects all ethnic groups. So CKD patients have a higher risk of adverse kidney and cardiovascular risk outcomes. And for over 2 decades, the RAS is the first-line antihypertensive agent in patients, CKD patients with hypertension, especially those taking 2 or more blood pressure medications to get their blood pressure to go. So RAS inhibitors includes ACE inhibitors or ARBs, have shown a reduction in albuminuria and also kidney protection by vasodilating in the efferent arterioles. This has helped lower the number of CKDs with high blood pressure. And for many years, there's no new pharmaceutical breakthroughs that significantly slow CKD progression until SGLT2 inhibitors were found to have renal protective effects. So these SGLT2 inhibitors are anti-diabetic medications that block the glucose reabsorption in the proximal convolute tubule, which is located deep in the nephrons of the kidney. They decrease the plasma glucose concentration and increase glucose excretion. So here we have 2 examples of SGLT2 inhibitors, canagliflozin and dapagliflozin. So I'm going to go quickly over the prescribing information. The canagliflozin brand name is called Infocana, and it comes in 100 milligram or 300 milligram tablets, while the dapagliflozin brand name is Farxiga, comes in 5 milligrams or 10 milligrams tablets. The canagliflozin has a black box warning, which is increased risk of leg and foot amputation. And then the warning for canagliflozin is hypoglycemia, and dapagliflozin is risk of bladder cancer. And the warnings and contraindications are they have some sort of kidney injuries to it. And the side effects are increased urinations, increased thirst, and also hypoglycemia. So next, we will look into the more closely at the canagliflozin and the effects of how the role it plays in the Credence trial, which stands for canagliflozin and renal events in diabetes with established neuropathy clinical evaluation. So did you know today that there are 3 million people worldwide are estimated to be receiving treatment for kidney failure? That is an alarming number, considering that this number will only increase to 5 million people worldwide by the year of 2035. And the primary reason for this global increase in kidney failure is contributed to the increase in number of type 2 diabetes in recent decades. So in cardiovascular trials, exploratory results suggest that SGLT2 inhibitors may improve renal outcomes in patients with type 2 diabetes. However, there was still some uncertainty because few patients reach end-stage kidney disease, or patients have low risk for kidney failure. Thus, the Credence trial was designed. So after the introduction of an anti-diabetic medication, the SGLT2 inhibitor, there were some signals that show that they can slow the CKD progression. And the proposed mechanism was the reason is that it can decrease in metabolic demand. So the purpose of the Credence trial is to assess the effect of canagliflozin on renal outcomes in CKD patients with type 2 diabetes and albuminuric CKD. So in clinical trials, scientists use statistical tests to accept or reject a null hypothesis. A null hypothesis predicts that there is no statistically significance of a variable interest on an outcome of interest. So if the null hypothesis is rejected, then an alternative hypothesis is accepted. And that variable interest does statistically affect the outcome of interest. So in this study, the null hypothesis is the canagliflozin would have no effect on the CKD progression in patients with diabetes. So here we're going to, in the next two slides, I'm going to go over the Credence trial design. And this is one of the largest studies being done in 34 countries with 12,900 patients screened and 4,401 randomized between March 2014 to May 2017. These were done as a randomized, double-blinded placebo control, and they included CKD patients who are over age 30, who had the hemoglobin between 6.5 to 12%, with the exception of Germany, where it was between 6.5 to 10.5%. And then the eGFR is 30 to less than 90 milliliters per minute. And then the UACR is over 300. And then they excluded patients who are type 1 diabetic and patients who are on dialysis and have kidney transplants. The primary outcomes of this trial is that there was composite of end-stage renal disease, doubling of serum creatinine for over 30 days, and death from renal or cardiovascular disease. And then there were other secondary outcomes listed here. Statistical analysis was set at greater than 4,200 patients to ensure that we have a power value of more than 90% and the alpha value of at 0.045. This was important because they want to show significance in canagliflozin of having lower than 22% compared to placebo. The intent to treat was a Cox model, both in the primary and secondary outcomes. So here we have the basically the timeline of the Credence trial. There are 5 phases. The first phase is screening the eGFR and the UACR. The second phase, we have a 2-week trial of single-blinded placebo run, which means that the patients either had canagliflozin or placebo. And what they found out was that actually 80% of them know that they had single-blinded placebo. And then phase 3 was pre-randomization, where there was stable, they have to be stable, have to be on stable ACE inhibitors or ARB for more than 4 weeks. Phase 4 is when they have randomization, where there's a double-blinded and that the canagliflozin was given at 100 milligrams orally once daily or placebo. And then at phase 5, we have after randomization, where the trial visits at week 3, 13, and 26, then alternate between telephone calls and in-clinic visits at 13-week intervals. So as you can see here, the Credence trial, that the demographic and characteristics, the canagliflozin placebo has very similar distribution of ethnic groups. And then on the chart here, we have the canagliflozin and placebo, that the average age was at 63 years old, and then the females were at 33.9 were women, percentage were women, and then the hemoglobin was 80.3%. Then the mean eGFR was at 56.2 milliliters per minute. And the mean UACR was at 927. Then for the results, what we noticed that during the phase 1 of the screening, patients were categorized based on eGFR or UACR. Later on, they were further grouped into primary composites or renal-specific composite outcomes. And here, the difference between the two groups is that the primary composite also included the CV death. So these were all plotted against the hazard ratio at 95% confidence interval at the dotted line, where you can see at 1.0. And if you look at this, all the majority of the average values, the dots, if you look at the blue dots, the average values, all of them are to your left of the dotted line. And then the margin of error are the lines that run across the blue dots, indicates that canagliflozin performs better than placebo. Then for the primary outcome results, what we have here are the graphs were measured with the primary composite in the center, with the x-axis on months since randomization, and the y-axis with patients with an event in percentage. The orange color is placebo, and the blue color is canagliflozin. And then below these graphs, we notice there's hazard ratios, and then the events per 1,000 patient year. And if you look on your lower left corner of the graph, your PowerPoint slide, you notice that the end-stage renal disease is on your left, and then the right side is death from CV causes. If you look at all of these graphs, what you notice is that they show statistically significant, except for death from CV causes. Even though there's a strong trend toward canagliflozin. And then here is a secondary outcome result. And what you notice here on the same thing on the x-axis, we have months since randomization, and on the y-axis is patients with events in percentage. And the renal-specific composite outcome is on your left, and then the dialysis kidney transplant is on your right, or renal death. And then on the middle center is a death from any cause. So if you notice from all of these, all the categories are statistically significant, also again, except for the death from any cause. So in this trial results, we are looking at the effects of albuminuria and estimated GFR. And these are done in tox model, where they look at the relationship between canagliflozin and placebo. And in the intent to treat population, what we notice here on the x-axis is months since randomization, and on the y-axis is UACR, which is urinary albumin creatinine ratio. And if you look between the placebo, which is in orange, and canagliflozin blue, that they're both consistent and parallel between the two of them. And then on the right side, we have the on-treatment population. The x-axis is months since randomization, and the y-axis is the estimated GFR. And then what we notice is that the placebo and the canagliflozin, there's a flip at month 12. And what that shows is that in the long run, canagliflozin shows a small change in GFR, but better albuminuria outcome. But it's important to note that the initial drop in GFR then stabilize and benefit patients in the long run. So for the safety analysis, they were conducted in all patients who had undergone on-treatment participants. And in general, what they noticed that the adverse events were similar in both canagliflozin and placebo groups. There is no significant differences in the risk of lower limb amputation, fractures, and diabetic ketoacidosis. Although the number in the diabetes ketoacidosis is a bit higher than placebo, as you can see from 2.2 in canagliflozin versus 0.2 in placebo per 1,000 patient year. And the limitations in this study are that they have early termination of secondary outcomes, no measurements of off-treatment GFR, and they also excluded non-diabetic patients, kidney patients. So this Credence trial was supported by Janssen Research and Development. So all in all, this Credence trial showed that long-term administrations of canagliflozin 100 milligrams daily in CKD patients with type 2 diabetes have a lower risk of primary composite. And I do want to note that canagliflozin is currently approved to reduce the risk of cardiovascular mortality patients in CKD with type 2 diabetes and patients in ASCVD. Next, we will look at another type of SGLT2 inhibitors, the dapagliflozin, and its role in the Dapa-CKD trial. This stands for dapagliflozin and prevention of adverse outcome in chronic disease. So here, did you know that today 700 million people worldwide have CKD? And again, this is also another alarming number with CKD worldwide, and considering that there are only few clinical trials conducted for kidney disease until recently with the Credence trial, we saw that the primary result shows that long-term administration of canagliflozin show that there are renal and cardiovascular protection in CKD with type 2 diabetes. However, the underlying mechanism and benefit of SGLT2 inhibitors in CKD patients may be due to natriuresis and glucose-induced osmotic diuresis, which led to the reduction in intraglomerular pressure. So that's why we see that the hemodynamic effect for the SGLT2 inhibitors may preserve kidney functions in CKD patients without type 2 diabetes. So the purpose of the Dapa-CKD trial is to assess the long-term efficacy and safety of SGLT2 inhibitors in dapagliflozin in both CKD patients with or without type 2 diabetes. So in the next two slides, we're going to go over the trial design of the Dapa-CKD trial. Here is another large trial conducted in 21 countries with 7,517 screened randomized patients between February 2017 and June 2020. This trial design is randomized, double-blinded, placebo-controlled, and patients with GFR ranges between 25 to 75 milliliters per minute, and UACR is between 200 to 5,000, excuse me. So CKD patients who are excluded include type 1 diabetic patients, polykidney disease, and other patients who are taking immunotherapy drugs of less than 6 months. So the primary outcome for this trial is that the first occurrence of any of the following includes the compulsive decline in estimated eGFR more than 50%. Then we also have end-stage kidney disease or death from renal or CV causes. The secondary outcomes includes composite kidney outcome or composite CV outcome or death from any cause. The statistical analysis for this trial was set at 681 primary outcome events. To increase its power of over 90% and a two-sided alpha value at 0.05 for its error of margin. And this was important to make sure the significance of the primary outcome was 22% lower in relative risk in dapagliflozin than placebo. The intent to treat is a Cox model. So here we have the timeline of how the Dapa-CKD trial was done. There were 4 phases. Phase 1 was a pre-screening to ensure that patients were stable with ACE inhibitors or ARB for more than 4 weeks. And phase 2 was that there was a GFR or UACR screening. Then phase 3, there was randomization of double-blinded of dapagliflozin 10 milligrams once daily or placebo. All right. And then they also have type 2 diabetes, either yes or no, and then UACR above or below 1,000. Phase 4 is after randomization, where we have a trial visit at week 2, then at 2, 4, and 8 months, and followed by 4 months intervals thereafter until the end of the trial. Here we looked at the demographics and characteristics of the patients in this trial. If you notice that the dapagliflozin and placebo in the pie graphs are pretty similar, so they're pretty equally distributed among the various groups. And then the average age was at 62 years old, and roughly 33% were women, and 67.75% had type 2 diabetes, while the mean eGFR was at 43.1 milliliters per minute. So here we have another result that shows the primary composites, and they're separated by the pre-specified subgroups of the eGFR, UACR, and the systolic blood pressure. And as you can see, majority of the black dots, or the average values here, and the margin of error, the lines across the black dots, are to the left of the dotted lines, which is the hazard ratio, 95% confidence interval at 1.0. This indicated that dapagliflozin performed much better, a lot better than placebo. And this next one, we'll look at the results of the primary outcome, where the x-axis is months since randomization, and the y-axis is in cumulative incidence by percentage. The red lines are placebo, and the blues are dapagliflozin. What we notice here is that the dapagliflozin was at 2.9 events per 100 patient year, better than placebo. And then for the secondary outcomes, the x-axis, we have months since randomization, and the y-axis is cumulative incidence by percentage. If you look on your left, it's the renal-specific compulsive outcome. Then on the right is the compulsive death of CV causes, our hospitalization for heart failure. And then the middle is the death from any cause. And if you can see from all this graph, it shows that dapagliflozin is significantly because it's always below the placebo line. And then right here, we have the results for the effect of estimated GFR. And the x-axis is months since randomization, and the y-axis is the eGFR. Again, the placebo is in orange, red, and dapagliflozin is in blue. And if you notice that around month 13, 14-ish, we notice that there's a flip. And this also kind of show us the same idea that dapagliflozin primary result is effective in the long run. So if you look at the safety of dapagliflozin safety, they were conducted in all patients who had undergone one randomization and taken at least one dosage of dapagliflozin or placebo. And what they noticed here that in general, the adverse events were very similar between the dapagliflozin and placebo group, except for the diabetic ketoacidosis and Fournier's gangrene, where they noted that the placebo participant. And if you look at this, that there is noted that there is no events shown in the treatment group. But we want to notice that the benefit is that there is no cases of diabetes ketoacidosis or hypoglycemic episodes were observed in this trial. The limitation of this trial is that there were early termination, which may reduce the power and the secondary outcome, and they didn't collect off-treatment eGFR. And then this trial, the Dapa-CKD, was supported by the AstraZeneca. So all in all here, this Dapa-CKD trial shows that long-term administration of dapagliflozin 10 milligrams in CKD patients with or without type 2 diabetes have a lower risk of primary composites and death from cardiovascular causes. So now we answer the question for the SGLT2 inhibitors in CKD. Is it kidney protective? Well, according to the Credence and the Dapa-CKD trials, we both noticed that they do have shown benefits where there is significant preserving the kidney function and prevention of cardiovascular disease with or without type 2 diabetes in CKD patients. So here, I want to conclude with that canagliflozin 100 milligrams and dapagliflozin 10 milligrams, that the benefit is that they improve glycemic control, reduce risk of hospitalization with type 2 diabetes and CVD. They also reduce the risk of end-stage kidney disease, doubling serum creatinine, CVD, and hospitalization for heart failure with type 2 diabetes and CKD. And then notice that the two different eGFR is that canagliflozin works with over 30 milliliters per minute, while dapagliflozin in this trial was looked at the eGFR of over 25 milliliters per minute. And the limitations of this trial is that they did not perform in type 1 diabetes patients and polycystic kidney disease or patients on dialysis and kidney transplant. So before I conclude, I want to say that so here are my references, and I hope that this educational seminar has been informative for you and that you're more informed about the drug you're taking and actually involved in bettering your health. Great, thank you for your time and taking the first step in improving your health. And at this time, I'd like to open the floor for any questions for myself or Dr. Ahearn.
Thank you very much, Dr. Tarkul. Since I forgot to record, I'm going to introduce Dr. Ahearn again. Dr. Patrick Ahearn, he's going to answer some of our questions along with Dr. Tarkul, is a clinical assistant professor of nephrology at Stanford University, where he cares for patients with kidney disease both before and after kidney transplantation. He completed medical school at UC Irvine, internal medicine residency at UCLA, and fellowship at UCSF and then Stanford. Dr. Ahearn's academic work includes investigating methods to improve outcomes after kidney transplant and to promote living kidney donation. So we do have a couple of questions in our Q&A, and if you have questions, we encourage you to submit them. I know the chat feature is closed, but you can submit questions in the Q&A, and that's at the bottom of your screen. So our first question is, would SGLT2 also help with proteinuria? And if so, how?
Sure, yes. So I see this question and I'm happy to answer it. It's a really good question. I'm not sure, it was in the slide about the canagliflozin trial and the Credence trial, but it did show that there is about a 30% drop in proteinuria on average in people who are taking the SGLT2 inhibitors. And the mechanism is pretty similar to the reason that ARBs or ACE inhibitors decrease proteinuria. And that's because there's a little bit of decreased glomerular filtration rate. And so you'd have less hyperfiltration. That's the main reason there. And they do help.
And I think you ended up answering this question. These medications are applicable to non-diabetic patients, right?
Right. Yeah. So that was why the Dapa-CKD trial was performed, was because there was a question of whether or not these medicines were safe and effective in patients without diabetes, and really, really good results showed that they were.
So what should we think about these commercials that we're seeing on TV that is promoting specifically Farxiga for CKD to help slow down kidney disease?
For Farxiga, I think, commercials on TV are a uniquely American thing that happened. I don't strongly recommend that people pay too much attention to commercials for pharmaceuticals, but these medicines are generally really good, and anyone with kidney disease should be asking their doctor if they're right for them, if these medicines are right. I think that we have this question about dapagliflozin, which is Jardiance, and I think that in my practice, I kind of use all of these medicines interchangeably. They're all within the same class, and they all have pretty good effects. I haven't seen a really strong signal that one is particularly better than another. A lot of the times it comes down to what insurance a person has, because a lot of the insurance companies are contracted to provide one or another of the medicines. And so whichever one works best and easiest with the insurance, easiest and fastest with the insurance companies is the one they go with.
I know in my case, I had to get a pre-authorization from my doctor for insurance to pay for it. So.
Right, yeah, exactly. And sometimes the pre-authorization is only going to be for one version or another. It's not going to, let's say, it's not going to cover all different classes. And again, if you get pre-authorization for any, it's probably the right thing to do.
So a question, if you are pre-diabetic, I know that if you're not diabetic, you can take this to help preserve your kidney function. Would this possibly slow down developing diabetes, type 2 diabetes, since it's lowering the blood sugar?
So usually that's kind of a question about diabetes management more than CKD management. If somebody has, usually you don't start a treatment for diabetes until somebody has diabetes. So essentially what you'd be doing is treating diabetes before somebody has it in that case. And usually we don't do that. It's not usually necessary because they don't have diabetes yet. If somebody has kidney disease before they have diabetes, then maybe the medicine would be appropriate though.
Okay, yes, I was assuming disease was there.
Right. Yeah. Assuming, yeah, we're in a kidney disease specific question
Right.
area, but a lot of people don't have kidney disease and have prediabetes. And in those cases, I don't think that these medicines are really indicated quite yet. But you're right. If somebody has kidney disease and is prediabetes, these medicines are probably not a bad idea to start.
So which kidney patients should ask their doctors about this?
Especially anyone with diabetes, especially. I think anybody with, all of these studies had people with a little bit of proteinuria in their urine. So I think that people who have no proteinuria at all, there's maybe a little bit of debate whether or not these are the right things to do. But and then, if somebody's on dialysis, I don't think they really need to start these medicines. They're not going to have much of an effect for the kidneys. These medicines have also had, we didn't talk about the trials today, but they've also been shown to be quite protective against cardiac disease, even in people without diabetes. So, I think that there's anybody with heart disease should ask their doctors about these medicines. Anyone with kidney disease who's not on dialysis, I think it's the right thing to ask. I see a question about PKD, and it's a really good question. I don't think it's been studied yet. There's probably low downside to trying it, but there's maybe not as much upside. And I think there's some other medicines for PKD that people should be on first before they take these medicines. I think time will tell us a little bit more. I'm sure there's going to be trials that come about that say whether or not there's a benefit for somebody with polycystic kidney disease. And then, in my world, we were talking a little earlier, but transplant's another big area of interest as to whether the SGLT2 inhibitors are going to show to have benefit. I think right now, a lot of us are recommending people take them if there's an indication and they're more than 6 months or a year after transplant. The reason we don't start them early is because there's a risk of infections, and we don't have the trials yet to definitively show that they're beneficial. But mechanistically, we think that there's probably going to be a benefit with transplant, especially in people with diabetes, and especially if they have protein in the urine. But I think that it's another good question to ask your doctor if you have a kidney transplant, whether or not they think this would be something to try. And there's still not a ton of evidence in that case.
Fantastic. Do we have any other questions, or is there anything that either of you would like to add to the presentation? You had mentioned, this was in our talk earlier before we went live, that there's an initial drop in GFR when you start this medicine. Does
Right.
it eventually come back?
Yeah. So, unfortunately, these medicines don't reverse chronic kidney disease. I don't think we have any medicines that really reverse it yet. So what these medicines and ACE inhibitors and ARBs also do the same thing. There's an initial drop in GFR as soon as somebody starts taking them, but then over months and years, the GFR decline is less than the decline in somebody who's not taking the medicines. So after about a year, the curves cross. I think we showed it in 2 of the slides earlier today.
That was what that slide meant.
Yeah. So I don't know if you can, I think the clock was recorded, but if you go back to where those result slides were, you can see that there's initially the GFR is lower on these medicines, but then over time it winds up being higher on average. And that initial drop is why most of us don't recommend these medicines if somebody's GFR is already very low, because we don't want that initial drop to cause big problems. But still worth asking your doctor about them. Maybe your decline has been very slow, and maybe your doctor is a big believer and you can be followed very closely. And I think that in the nephrology world, a lot of us, we're really excited about these medicines because they're the first new treatments in 30 years that have shown such good outcomes.
That is wonderful.
Yeah. Looks like there's a question about any medications for PKD. There are some medications that are targeted at polycystic kidney disease. I think that it's a little outside of what we talked about today. So I think that if you have PKD, it's worth talking to your doctor about whether or not the medicines would be right for you. They're a class of medicines that that can slow down the cyst formation.
So these studies didn't take into account the causes of kidney disease, right? So it was hereditary, or if it was caused by large amounts of medicine or that kind of thing.
So the first study was only in people with diabetes and presumably had kidney disease from diabetes, but you're right, it didn't take it into account necessarily what caused the kidney disease. The second study let anybody with any type of kidney disease was allowed to be in it, unless they had a few certain causes. So polycystic kidney disease was excluded, kidney disease due to lupus was excluded, and then people who had been taking a lot of immunosuppression were excluded. So that's, again, some diseases wind up with that treatment. You know, a big question, a very common cause of kidney disease is IgA nephropathy. And it seems like these medicines help with IgA nephropathy. That was found from the second study we talked about. They did some subgroup analysis where they looked at people who were enrolled in the study with IgA and they had the same benefits as others. And then if people with kidney disease due to hypertension, it seems like these medicines are probably helpful, especially if somebody has at least a little bit of proteinuria.
Right.
Yeah.
There's a new question.
Let me scroll down here. Is Jardiance in the same category? Yes. So Jardiance is one of these medicines, and I would expect it to have similar benefits as well. So that's a good question. These studies were international studies. The question is, there's a high concentration of CKD in African Americans, which is true. And the African Americans were definitely included in these studies if they were eligible to be enrolled, but most African Americans for studies are recruited in America. And these studies were large international studies. But as far as I know, I don't have the exact subgroup results by ethnicity, but there's no reason to suspect that these medicines would not work, would be any less effective in African Americans. But that's a good question. And they weren't, nobody was excluded from these studies, and there was at least a percentage of African Americans included in these studies. And I would, again, encourage anybody with CKD to ask their doctors about these medicines.
I want to thank you both for just such an interesting presentation. It's so exciting that the drug companies are starting to create drugs that can help us.
Yeah, it's really great.
Slow down the progression and hopefully one day, you know, keep us from having to go on dialysis.
Exactly. Less dialysis, you know, kidney transplant is always put a plug in for that. If you think you might need a kidney transplant, please ask your doctor to go visit a kidney transplant team as well. If it looks like you're heading in that direction, the sooner the better.
Amen to that. I told them earlier, today's the 8th anniversary of my kidney transplant from a living donor. So I'm very much in favor of.
Yes, very good.
So thank you both so much for this presentation. It was interesting. We're excited, and I hope that you can come back next year and give us even bigger and better news that
I sure hope so.
Keeps going well. So I think we've answered all the questions. Thank you very much. And this will be posted on our website this week.
Thank you.
Thank you for having me, and best of luck with everyone. Enjoy the rest of your day.
You too.
Bye-bye.
Bye.
Thank you again.